Hi everyone, Chang here. I'm the Specialty Lens Director in Cornea Service at Wills Eye Hospital, as well as the Senior Director of Medical and Surgical Operations in EssilorLuxottica. Here in Phoenix, giving a lecture on keratoconus update, describing and discussing current best practices in keratoconus management, both surgical and non-surgical, and also future highlights to watch out for. So in the interest of time, for those who miss my lecture, should never miss my lecture, but for those who miss my lecture, let me share some of the highlights that is coming down the pipeline that I think are worth watching out for. And so number one, last year at ESCRS 2025, I actually collaborated with a group of investigators from Australia. We looked at charts of treatments in progressive keratoconus patients after being treated epi-on cross-linking, but in a topography-guided fashion. So we all know that epi-on cross-linking has recently been, at the end of last year, been approved in FDA with oxygen supplementation. This one takes it, brings a very interesting variation in that instead of uniform UV energy treatment field, you place different amount of energy, higher level in the area that's presumably weaker, meaning around the apex, and going outward, so it's topography guided. These progressive keratoconus patients were tracked for up to 24 months, comparing their best corrected visual acuity, higher order aberration, and their corneal tomography and corneal biomechanics, which is an instrument that's not yet available in US yet. So, and neither is the topography-guided treatment of cross-linking. So we show very favorable results despite being epi-on, that patient stability is being maintained in the group of keratoconus, progressive keratoconus patients. So definitely worth watching out for that. As well, the second thing that I think is very interesting, sort of the age-old question that we all have been asking for. Are there more treatment options for keratoconus patients and potentially less invasive? Obviously, epi-on cross-linking fits that category, but can it be even done potentially with an eye drop, for example? There have been some research in that, and even adding to it more recently in Australia, a study was started. It's an open-label, preclinical, if you would, proof of concept, dual-arm study where you will randomize treatment of patients using an eye drop, which contained, according to available information, contains transforming growth factor beta 3 as well as dexamethasone. And the transforming factor is known to upregulate collagen production. So presumably, it will lead to collagen proliferation of the healthier collagen fiber formation with more cellular bonds that provides cornea with increased rigidity and therefore stopping progression in keratoconus. Again, very new, this research, and I think it's worth keeping an eye out for, especially for our patients. Obviously, a lot of misconceptions, I think, that patients, whether from their family friends or from Dr. Google, they may find different information. I do find one that recently have been brought up to me by patients over and over again that I find somewhat disturbing is that patients often blame themselves. They see the information on how eye rubbing is related to, or at least as part of the cause for keratoconus, and rethink how many times they've rubbed their eyes over their lifetime, and they live with tremendous amount of guilt. Now, while it is true that eye rubbing is a factor, so is interplay between genetics and environment, right? We must obviously control eye rubbing, whether it's due to a seasonal allergy or allergy period, or dry eye and other ocular surface diseases that we can control. While that is true, we definitely need to educate patients to avoid eye rubbing, but we also need to educate patients in a way that does not place the blame on patient so that they don't think that they have self-inflicted themselves with a disease that is visually devastating. So I know we can do it, and looking forward to your comments and seeing you next time at a future lecture. Thanks, everyone.